Excellent. Good morning, everyone. Thank you for joining us today. We are really excited to have Dominique Bertrand from Rouen Hospital, University Hospital in France. Dominique is a clinician scientist there, and he heads the kidney transplant program for both deceased donor as living donors. He's a clinician scientist, and his research is on the topic that he's going to talk about on desensitization of highly sensitized candidates on antibody-mediated rejection and belatacept. Welcome.
Yeah, thank you so much for your kind introduction. Um, Thank you. I'm very happy to be there to discuss with you about this very hot topic on the highly sensitized patient and to present the French experience on the Imlifidase. So the question is, how can we improve the access to kidney transplantation in highly sensitized patients, but in very highly sensitized patients? So first, we have to make some definition. It's very important to define what is a sensitized patient. So a sensitized patient is a patient who have at least one anti-HLA antibody secondary from previous exposure like transfusion, pregnancies in women, or prior transplantation for patient. So this is a sensitized patient, but what is a highly sensitized patient? So the definition of highly sensitized patient is based on the CPRA, the calculated panel reactive activity, and this is an estimation of the proportion of deceased donor population against which the candidate has at least one anti-HLA antibodies. And the population, the donor population, depends on the country, is different from one country to another. For example, in the Eurotransplant zone, this is a fixed cohort of 10,000 donors. In the USA, this is a fixed donor too, a fixed cohort, so sorry, about 12,000 donors. And in France, this cohort each is changed every day, every night. And this is the donors from the last 5 years. And in France, you are considered highly sensitized patient when your CPRA is higher than 85%. Okay, so this is the definition of highly sensitized patient, and there is one more definition important. This is the concept of donor-specific antibody. As you know, many patients, many highly sensitized patients have a very important proportion of antibody, and some of them could be directed against a potential donor. And this is what we call preformed donor-specific antibody or preformed DSA. And their presence at kidney transplantation significantly increases the immunological risk of transplantation. That's to say the risk of antibody-mediated rejection. Okay. So it is important to understand that highly sensitized patients have changed from the test to detect the antibodies. Initially, the tests were a cytotoxic test, then changed to ELISA, and now we have the Luminex technology to better screen the anti-HLA antibody. We have a better sensitivity, but we have a specificity which decreased along the time. So it is very important to understand that this is a very important issue in kidney transplantation. And we have to be very cautious to interpret the Luminex test. Why? Because the cutoff for pathogenic antibody is not well defined. And there is a very important interlaboratory variability. Then there is probably some difference between suppliers of the Luminex test. As you know, there is one Lambda, Immucor, Thermo Fisher, and Werfen, that's the same. And there is many differences between the two suppliers. So we need there is a very important need of standardization for the use of Luminex testing. And as the Luminex uh, um, come with the advent of Luminex technology, the number of highly sensitized patients increased dramatically. You can see here the wait list in France, and when the single antigen Luminex came in 2008, you see the proportion of highly sensitized growing very, very fast, from less than 500 kidney transplants, weighted listed patient, to more than 3,000 patients. So this is a very important topic, because there are more and more patients who are waiting on the list with high CPRA. And I think the message is here. The mortality increase linearly with CPRA. So we have to get an access to kidney transplantation for those patients, because the mortality raised with the CPRA, and the first cause of mortality is cardiovascular in this huge study from the USA. So what can we do? In highly sensitized patient, the approach have to be a stepwise approach. The first message and the first step is to avoid immunological conflict. If we can do that, it's better for the patient. That's to say, we have to perform kidney transplantation without preformed DSA. Why? Because the immunological risk is less, and there will be no DSA. The risk of antibody-mediated rejection is low, and the cross-match is negative. So this is the first step. So how can we do this first step? We can give a priority for highly sensitized patients on the waiting list. This is the UNOS system, and in this waiting list, there was an accumulation of very highly sensitized patients in the waiting list. So recently, the allocation system changed, and under the new allocation system, additional points are awarded for sensitization, but on the sliding scale. So the higher is the CPRA, the higher is the points that will be awarded to the patient. And it works. As you can see, before the new allocation system, 2% of transplant went to CPRA 19 to 20 to 100. But after the change of the allocation system, as you can see, the part of highly sensitized patient was very, very higher than previously. So it works. It works, but till a certain point. Why? Because as you can see, if we check 5 years for the new listed patient, 5 years after the listing, as you can see, the patient with the highest CPRA are still on the waiting list. More than 50% are on the waiting list. So very, very highly sensitized patient won't benefit from this program. So this is the first possibility. But the other possibility is to use the acceptable mismatch program, as in Eurotransplant or as in France. This is also the case. So what is the acceptable mismatch program? This is the extension of the HLA phenotype of the patient. You take the phenotype of the patient, but you consider also the acceptable HLA antigens as his own phenotype. And the acceptable antigens are the antigens against which the patient have no antibodies. So you create an extended HLA phenotype. It could be an option for a transplantation for the patient. And it works also. As you can see in neurotransplants, 50% of the highly sensitized patient listed get a transplant after less than 2 years. So it's good. And the results are very nice. As you can see here, the graph survival in highly sensitized patients is comparable to low sensitized patients, and is better than the program previously used. So it's very interesting. But This is the same case in France. In France, we use an acceptable mismatch program. This is the result in 2023 in France. And as you can see, the part of highly sensitized patient is high, is about 20%. And every year there is new listed patient with high CPRA, and there is an accumulation of those patients on the list. And the deaths of those patients are quite high. So we wanted to know about a more precise view of the CPRA in France, and we performed this study with colleagues from 13 French Center of the Spicer Group to understand the access to transplantation according to the CPRA. So we perform a study on about 15,000 active waiting listed patients during a 10 years period. And we check about the transplantation, the cumulative incidence of transplantation according to the CPRA. This is a fine and gray model. And as you can see, when you have a CPRA higher than 95%, as you can see here in the forest plots, your access to transplantation is not so good, even if you have the acceptable mismatch program. But if you check more precisely, uh, to up to 95%, the access to transplantation is very good and is comparable to those who are not sensitized. So up to 95% in France, the access to transplantation is very good. But after that, we have to find another solution for those patients. And if we check about the cumulative incidence of death or delisting in those patients, this is the same. So up to 95, 96%, it's okay. The risk is not, it's comparable to those not sensitized, but from 97%, the cumulative incidence of death or delisted is higher. So a better approach is highly needed in this highly sensitized patient. Okay, so what can we do? This is the second step of this stepwise approach. We have to perform immunological high-risk transplantation. That's to say we have to perform transplantation with preformed donor-specific antibody. This is a higher risk of antibody-mediated rejection, and we have to make kidney transplantation with positive cross-match. So what do we need to perform high-risk immunological transplantation? Okay, we have to perform the Luminex test, and based on the intensity of the DSA, the risk will be higher and lower. We have to perform the flow cytometry cross-match, which is more sensitive than the CDC cross-match, the cytotoxic cross-match based on the complement activation. So, and we have another tool, which is the dilution of the Luminex test to understand how high is the immunization in those patients. And then we have to stratify the risk. We can make a natural desensitization, we will talk about in a few minutes, and the risk is lower than make an active desensitization. And the higher risk is when the CDC cross-match is positive, the flow cross-match is positive, and your DSI, your preformed DSA are positive. Okay, this is the stratification of the risk of antibody-mediated rejection after kidney transplantation. Okay, so this is the approach we use in France. So for the ICPRA higher than 97%, when the patient is on the waiting list more than 3 years, we analyze again the last serum, the last blood test to detect the antigen, to detect, the anti-HLA antibodies. And in some patients, there is a decrease or a disappearance of anti-HLA antibodies. And This is the natural desensitization or the passive desensitization. So we will make a transplantation with historical donor-specific antibody. On day 0, there is no DSA, but there is a cellular memory. So we can perform those kind of transplantation, which have a good evolution, but take care because there is a memory, and then this can what can happen? A rebound after the kidney transplantation. And the risk of antibody-mediated is probably between 20 and 30% after the kidney transplantation. But this is a possibility. And a very important tool in this case is the Luminex test, because the higher is the MFI, the higher is the risk of rejection after transplantation, and the MFI have to be evaluated at the peak before transplantation. Okay, so this is a natural desensitization, but sometimes is not sufficient. As you can see here, the Luminex test in one of my patients, on the last serum, the CPRA is still 100%. So if we don't do anything, this patient won't get an access to kidney transplantation. Okay, so what is the second step? The second step is in those patients with persistence of anti-HLA antibodies, we make a dilution of this serum. And if there is a decrease after the dilution on HLA antibodies, we can propose an active desensitization in this patient. Nevertheless, we have to consider active desensitization with caution. Why? Because the results in the literature is not so clear. As you can see in the United States, this is the study performed by R&D in the New England in 2016, and the survival of desensitized patient was higher than waiting a kidney transplant on the waiting list. But if you check the same study in the United Kingdom, the survival was exactly the same between this kind of patient. Okay, but there is probably a higher risk of ABMR after those kind of transplantation. The infectious risk is higher. So the survival could be the same, but we have to consider also the quality of life of those patients waiting on dialysis, maybe for 5 years or 10 years. So we have to discuss this potential treatment with the patient. Okay, so the risk of ABMR after active desensitization is higher, and it depends on the positivity of the 3 tools. It depends on the positivity of cross-match, of CDC cross-match, and when the CDC cross-match, the risk of ABMR is quite high, about 50%. So this is important to take into account when you want to perform a kidney transplantation with active desensitization. And the percent of graft loss after those kind of transplantation is higher when the 3 tools are positive. But when the flow cross-match is positive and the CDC is negative, as you can see here, the percent of graft loss is very lower. Okay, an important concept is the risk of infection in this kind of population because the immunosuppressive therapy use is higher than in other kidney transplantation. And in this study performed in 2020, the higher is the desensitization, the higher is the risk of infection, both community infection, but also opportunistic infection in this kind of patient. And as you can see here, in the high intensity of desensitization, the cumulative incidence of infection is very high. And this is probably the first cause of death in this kind of patient, because as you can see, the higher the risk of death is also coming up. So the mortality in those kind of patients is higher when you take an important risk of ABMR after the kidney transplantation. Why? Because if you take a risk of ABMR, you have to treat ABMR after kidney transplantation, and you add in the immunosuppressive therapy. Okay, so we make a desensitization, active desensitization, but how we made now the desensitization? Uh, as you can see, we can perform active desensitization before kidney transplantation, on day 0 of kidney transplantation, or after kidney transplantation. We can begin with after kidney transplantation. You perform a kidney transplantation, and at day 0, you have a preformed DSA. Your CDC cross-match is negative, but you have a DSA. So what could you do? This is the experience for Necker Hospital, a large series published in Transplantation in 2017, and they use IVIG, rituximab, and plasma exchange after transplantation. But the risk of ABMR is high, is about 30 to 40%, but it's a possibility. But your cross-match is negative. You can make it before kidney transplantation in very high sensitized patient with high CPRA, initially with IVIG. This is the experience for Stanley Jordan team, and in France with Denis Glotz. At time of the use of IVIG, it worked, but at that time, the screening of HLA antibodies was not the same. So initially they use IVIG, then IVIG plus rituximab, and then plasma exchange, rituximab, and IVIG. So this is a possibility for patient. But when you use plasma exchange, rituximab, IVIG before kidney transplantation, it's very heavy for patient. So it's not always the solution. And now there is new drugs, anti-IL-6. It's a possibility, like tocilizumab before transplantation, and a very important drugs, this antiplasma cells therapy like daratumumab or isatuximab, with very good study recently published. And there is another study in the now which are in perform, like with belatacept and daratumumab, but we don't have the results yet. And to the end, we can perform the desensitization on day 0, and this is the topic of my presentation on imlifidase. So what is imlifidase? Imlifidase is an enzyme from Streptococcus which cleaved immunoglobulin G. Okay, so only one infusion, about 20 minutes, and in some hour, you don't have any more IgG. And this IgG will be very low in about 3 to 7 days. So this is the IgG, but we want to know what is the results on HLA antibodies and DSA and preformed DSA. And as you can see, in red, you have the intensity of anti-HLA antibody before treatment, and in blue, after treatment. So there is a real decrease of DSA during the first day of transplantation. And this is very important to open the door to those very highly sensitized patients. So it's beautiful. But what is the problem? The problem is that after 7 days, 10 days, there is an increase of both IgG and also HLA antibodies. And we will have to control this rebound, because there is a risk of ABMR after that. Okay, so what is the results of the first study performed? This is the biggest cohort with 3-year and 5-year published results, about 40 patients with more than 80% of deceased donor. As you can see, the rate of ABMR is about 40% of patients, but with a high risk of ABMR, the results at 3 years for patient survival and graft survival are very good. And there were recently published results at 5 year, and at 5 year, the eGFR was very stable. So this is a good news, and the DSA were quite low at 5 years. So it's a good news, but we don't have the more important results we wanted to have. This is the histological results. What are the results at 5 years? Is there some chronic ABMR? We don't know that yet. So the 3 key messages from the phase 1 and 2 from this drug is, first, the conversion of baseline positive cross-match to negative in about 80% of patients. This is very important. Second message, the antibody-mediated rejection occurs in about 40% of patients transplanted with imlifidase. But despite the high rate of rejection, the 5-year graft survival is about 80%. This is very important in those kind of population with very high risk of ABMR. Okay, so when it comes possible to use these drugs in France, we try to make some recommendation or guidelines with some colleagues for the use of imlifidase in this kind of population, for using this drug with some homogeneity in France. So these are the criteria we use to define the population in which we can use belatacept. So we have to select the patient, and the patient eligible for this treatment is patient with high CPRA, higher than 97%. We have to take patient with age lower than 65 years old, and with a time on the waiting list about more than 3 years. Why 3 years? Because we want to perform transplantation without immunological risk in first intention. So we wait 3 years on the acceptable-mismatch program. And then we want to perform those kind of transplantation in center with access to plasmapheresis 7 days a week. Why? Because it can occur a rebound of DSA and the risk of ABMR. So we have to be very cautious and to be active on it. And then we delist HLA antibodies on the waiting list. Which antibody we can delist? We delist antibodies with MFI not exceeding 5,000 after a 1 in 10 dilution in the last serum of the patient. So when we make this delisting strategy, we will have a drop of CPRA. And after this drop, we can have an organ offer. On the day of the organ offer, we have to have at least 1 DSA exceeding 6,000 to use imlifidase. If on the day of the organ offer we have DSA below, we don't use imlifidase. And we have certainly a need for a pre-imlifidase virtual positive cross-match on the recent serum. Okay, so when we have all these criteria, we perform an infusion of imlifidase, and 4 to 6 hours of the infusion, we make a CDC cross-match. And if it's negative, we can perform the transplantation. And retrospectively or prospectively in some center, we made a flow cytometry cross-match to stratify the risk of ABMR after the transplantation. This is the immunosuppressive regimen used after kidney transplantation with the use of imlifidase. And the message is we can't use IgG-based treatments that imlifidase could cleave. So we won't use ATG. You can use ADGAM from horse IgG directed for against lymphocytes, but you can't use rabbit ATG. You can't use IVIG. You can't use rituximab. So during this period, uh, the point important is that the IgG is very low. So the risk have to be low. But you have to know to establish your immunosuppressive therapy. So we perform this kind of transplantation with higher dose of steroids during the few days after transplantation because we know we didn't have ATG during this day. And at day 4, we can use the ITG and the IVIG. And on day 7, we perform an infusion of rituximab. Then we use tacrolimus and mycophenolate mofetil. Okay, this is the first published data from France of the 9 first patients transplanted with imlifidase, recently published in international reports. And the first results were good. Good from a safety view, and for the first results of ABMR, ABMR active and where clinical ABMR was about in 20%, but for the first 3 months, the EGFR was very good. But this was a first result for the 9 first patients. Now I will share with you the first experience to date, unpublished data presented at the ESOT recently. During since 2 years, 3 years, there were about 100 of kidney transplant candidates with early access to imlifidase, and 30 transplantation were performed. To date, on 2 days number is about 60%. 60 kidney transplantation with imlifidase. But I will share with you the result on 30 transplantation performed in France. So as you can see, this is young people, 48 patient, 48 years old in mean. Most importantly, on dialysis, some patient, as you can see here, the mean is about 10 years of dialysis, mainly second transplantation. And the most important, as you can see, is the CPRA on the last SIRA. And on the last SIRA, most of the patients were higher than 99%. And when you delist, you see the drop of CPRA. The drop is 65%. So the patient have an access to transplantation, and we perform 30 transplantation with this drop of CPRA. So this is the immunosuppressive therapy. So not a lot to talk about that. All patients receive rituximab, pre-transplant or after transplantation. And this is a very important information about the risk we take for those patients, because as you can see, the immunodominant preformed DSA was about 10,000. And if we check at the sum of the MFI of all the DSA, this was, as you can see, about 20,000 in the patient. So this is the high risk transplantation. So conversion of cross-match were effective in all the patients. We performed 4 patients with CDC cross-match positive, and all the other are flow positive, flow cytometry positive transplantation, and all the patients were converted after the infusion of transplantation, infusion of imlifidase, sorry. So what is the follow-up? The median follow-up is 10 months. We don't have graft loss. One patient died on month 1 from a septic shock, but with a functioning graft, and 29 patients have at least 3 months follow-up on this data. We can take the rebound, and the rebounds occur in in a very high proportion of patients, because there were no rebound in 6 patients, and all the other patients have a rebound after kidney transplantation. Rebound of the DAC. So this is the occurrence of clinical rejection after transplantation, and rejection occur in 10 patients after kidney transplantation, very early after transplantation, probably during the rebound. And you can see the treatment used for this rebound after kidney transplantation in patient with clinical antibody-mediated rejection, mostly with eculizumab therapy in this patient. Okay, this is a few patients, but if we check the risk of antibody-mediated rejection according the rebound or not, this was not significant, but probably because that's what not powerful to detect a significant difference. Okay, if we take into account the clinical antibody-mediated rejection early and the antibody-mediated during the first 3 months, the rate of AMR was about 50% of this patient. Okay, but one important thing is to check about the kidney function in the last follow-up, which was quite good in this kind of patient, with a median follow-up of 10 months in 30 patients. This is the rate of infection. Not very important, and as you can see, the most important infection was urinary tract infection, but I think it's not a very important issue in imlifidase treatment. For infection, we have to wait because it's very early. We have to wait after 1 year, 2 years, 5 years, the rate of infection because of the cumulative drug immunosuppressive. Okay, so what is the first conclusion of this first real-life experience? This is a highly selected patient because we made some recommendation. All the clinicians in France follow this guideline. So they are a young patient waiting on dialysis about 10 years with very high CPRA, IDSA, preformed DSA at day of transplantation, with positive flow cross-match in all patients and positive CDC cross-match in about 50% of the patient. The conversion of baseline positive cross-match was effective in all the patients. The rebound occurred in 80% of patients, and most frequently with repeated HLA mismatch. This is a very important information. The antibody-mediated rejection occurred in about 1/3 of patients with clinical AMR, but also with subclinical AMR in 3 months protocol biopsy. The graft function was good at the last follow-up, and the short-term survival, graft survival was excellent with an acceptable safety. Okay, this is the end of my presentation. So if I can sum up for the take-home message, I think the most important is, okay, patient with very high CPRA on the waited list are waiting for a kidney transplantation. And we have to improve our strategy for those patients. We can transplant those patients avoiding immunological risk. And this is the power of the allocation system. Here in France with the acceptable mismatch, but in other countries with other programs. But for very highly sensitized patients, we have to be more active with a natural desensitization and delisting some antibodies, and if it did not work, with active desensitization. And I think today for kidney transplantation with deceased donor, I think imlifidase is the best solution for those patients. So thank you for your attention. I would like to thank my friends and colleagues for the recommendation on imlifidase, and my friend from the Spicer group from the study we performed for the access on transplantation according to the CPRA. Thank you so much.
Fantastic. That was an excellent presentation. Thank you again for giving us your experience and sharing the data. Corey, you have a question?
Sorry, Swap. It's David. I'm at the service B room, so under Corey's name here. Dominique, thank you very much. Merci beaucoup for that. My name is David. I'm one of the transplant nephrologists. A couple questions. So from what I gather, imlifidase is basically allowing you to get more acceptable mismatches with the delisting PRA that you, the delisting of the, let's say, previously unacceptable PRAs. I'm sure that despite that, you still have quite a few patients that are just not able to access transplant because they have too high MFAs or too many or what. Do you think that, I mean, even though, you know, the rates of ABMR are still kind of not negligible, I know that many patients would probably take that to get off dialysis. But do you think that this treatment could eventually, you know, be broadened to push it further to have even more patients open to transplant and kind of more aggressively delist those previously unacceptable HLA?
Yeah, thank you. It's an excellent question. Thank you very much. And I think it's the biggest issue in kidney transplantation for highly sensitized patients, because we stop there. As you can see, for the stepwise approach, we diluted the serum, and if there is a drop of CPRA, we can make an active desensitization. But I think in this step, about 50% of the patient have no drop of CPRA. So you're right. What can we do for those patients? I think it's, you know, I think it's very early with imlifidase. What we wanted to do in France is to begin with a medium risk of ABMR in this population. But I think the second step is to go further and to go with the patient without the drop of the CPRA. And there is two strategies. The first is to use imlifidase and only imlifidase, but to accept higher MFI and higher MFI when you diluted the serum in 1 in 10 serum, and you perform the transplantation. And you check at the rebound at day 7. Because this is, I didn't talk about that, but the patient with a CDC cross match with the higher MFI, CDC positive cross-match at day 0, with the higher MFI of preformed DSA, are not the patient who presented the most important ABMR, clinical ABMR after kidney transplantation. So I think there is some patient with higher MFI who could benefit from imlifidase without any other drug. So this is the first possibility. The second possibility is to use different drug. As you see, as you know, there is some study, and I talk a little bit about that, about anti-plasma cells therapy. Daratumumab, isatuximab, felzartamab, and I think if we use anti-CD38 therapy before transplantation, and a day of the transplantation, we use imlifidase, probably for those patients, it could be an option. But it's my personal feeling, but we don't have data about that. But today, for the very, very highly sensitized patient, I think there is no good option.
Thank you. And just if I can, just one more question out of curiosity. How are you guys having access to imlifidase? Is this all provided by the company? Is it in the context of a trial, or is it covered by insurances, or is it approved by European?
Okay, so initially that was an early access. Early access like monoclonal antibodies for COVID, etc. So that was the laboratory who paid the imlifidase. But from I think February 2025, this is covered by the insurance in France.
All right, super. Merci beaucoup.
Merci, ouais. Merci pour la question.
That's amazing that the insurance is covering that.
Yeah, because it is very, very expensive, as you know. And we always tell that okay, the first year or kidney transplantation is more expensive than 1 year of dialysis, but this is not the case here, because it's very expensive. But it's a small number of patients. So we have to take it into account when we want to start this kind of therapy.
Yeah, absolutely. Greg?
Thank you. Dominic, sorry, this is actually thank you. Dominic, sorry, it's actually a follow-up to David's question. I've got another question because I got maybe a little confused. The imlifidase, if I understood, was given right at the time of transplant. The drop of the PRA was a numerical exercise, correct? Where you said these
that's right.
are no longer considered DSAs.
It's
virtual. Related to the imlifidase.
It's very it's a virtual step. So you delist on the computer the antibodies, and then you see the drop. But this is virtual. The treatment is given on the day just before the transplantation. That's right.
Okay, perfect. Okay, and so my question, 2 questions. So did you see any early ABMR on that day 0 to 4 when you really couldn't use IVIG as a treatment? And then the second thing is we've done very low risk desensitization here in Ottawa, but they've been virtually all in our living donors. And have you had any experience in your living donor population with imlifidase?
Okay, so the first question, early ABMR, all the ABMR occurred after the rebound. So this was day 7, but earlier there was no rejection. We just have one case of T-cell mediated rejection early after kidney transplantation, maybe because there is no ATG, but this is only one case. For the second question, we also perform kidney transplantation with preformed DSA in living donor kidney transplantation, but without imlifidase, because there is it's not covered by the insurance in France for donor for living donor, also just for deceased donor. So in France, most of the living donor HLA incompatible transplantation are performed with apheresis, like immunoadsorption, plasma exchange, or double filtration.
And logistically, when you call someone in that you're going to be using the imlifidase and getting them ready, is it what's the average like length of time that it adds to getting them
Yeah.
OR?
So the question is what time they wait before the
Yeah,
transplantation?
like
Okay.
is it significantly impacting your cold ischemic time?
Yeah, it's huge because as you can see, the patient wait for many years on dialysis, and they were not called for kidney transplantation during 5 or 10 years, and in about 3 months they are called and they get a transplant. So it changed the landscape of those kind of patients.
Sorry, I meant once you've called the patient into the hospital the day of the transplant,
sorry.
is it adding to your cold ischemic time and getting them ready?
Yeah, that's right. We are 4 to 6 hours added to the ischema time. That's right, because we have to perform the cross match 4 to 6 hours after the infusion of imlifidase.
Okay, thank you.
Wow, that's amazing. I had a couple of I'm not a transplanter, so I have some other questions. You showed initially about the natural desensitization that happens in some patients. Do we have any outcome data, like how well do those patients do? Because I'm not
that's right.
sure how
It's
I feel about
very important. We're trying to perform this study in our center and in the SPICER group, but it's quite difficult because not all the clinicians they list on the same way. Okay, because here, for example, in Rouen, we take the last blood test, last serum, and when there are not antibodies, we delist those antibodies, even if they were very high in the past. And in other center, there is a limit with the intensity of the antibodies. So it's very difficult. But there is a good study recently published in Kidney International by the Spanish team with the delisting strategy. They delist for very, very highly sensitized patients, and in about this is the result for 30 patients, and they go well. But the risk of a BMR, if you have a preformed DSA, is higher and is still between 20 and 30%.
So you are able to get them a transplant with that, but with that higher risk of ABMR, which again, many patients will probably say that's an acceptable trade-off. Because otherwise they wouldn't have got a transplant.
That's right. But we have to discuss with them, because this is a complicated strategy. But if they are okay and they want to get a transplant, I think it's a good option for them.
Yeah. And one last question, if I can, what's the difference between horse and rabbit ATG? Why is one acceptable and the other one is not? I'm just curious about it.
Okay, so it's a nice question. I don't have the right answer, but when you make the test in vitro, the rabbit ATG are cleaved, but not the horse. I think it comes from the property of the streptococcus, of the IgG, of the enzyme of the streptococcus. But in vitro, there is no cleavage of the horse ATG.
Oh, that's amazing. Is there any
that's right.
Is there any research going on to say either to make a different version of imlifidase or to have a different version of ATG to counter these problems? I know it's such a small, tiny population, right? So industry cannot have enough interest in this area.
I think, but this was the first protocol. But I think that the use of horse ATG could be a very nice option, but it's not well tolerated compared to rabbit ATG. So
yeah, excellent. Yeah, thank you again for that excellent overview of the entire topic of the
thank you to you.
Patients. We have just started a few months ago doing the acceptable mismatch. So this was very timely from that nature. Maybe we can convince someone here to start
great.
imlifidase. But thanks for sharing your experience.
Thank you very much. It was a real pleasure to be with you.